Welcome back to the Head and Neck Oncology Channel Club. I'm your host, and this is episode 11. Today, we are looking at a paper that addresses one of the most common debates in thyroid surgery: what to do about postoperative hypocalcemia. The paper is titled Routine versus Selective Calcium Supplementation After Total Thyroidectomy, a randomized clinical trial, published in JAMA Otolaryngology on February 19, 2026 by Garcia Lozano and colleagues from Colombia. Some background. Hypocalcemia is the number one complication after total thyroidectomy, affecting up to 40% of the patients. For decades, we have had two main strategies to deal with this. Option 1, to give every patient prophylactic calcium and calcitriol postoperatively. Option 2, measure a postoperative PTH level and only supplement patients who have a low value. There has been plenty of observational data supporting PTH-guided management, but no high-quality randomized trial was ever compared these two strategies head-to-head until now. So this was a multi-center pragmatic diagnostic randomized controlled trial, what the authors called a DRCT, conducted across 3 tertiary hospitals in Colombia. They enrolled adults undergoing total thyroidectomy for benign or malignant disease and randomized them 1:1 to either routine calcium and calcitriol supplementation for 15 days or selective supplementation based on a 4-hour postoperative PTH level. In the selective group, if your PTH was below 15 picograms per milliliter, you got the same supplementation. If it was 15 or above, you got nothing. They randomized to 330 patients and analyzed 258, 117 in the PTH-guided group and 141 in the routine supplementation group. The groups were well balanced, mostly women, about 85%, mean age around 50, roughly half with malignant pathology, predominantly papillary thyroid carcinoma. About 20% underwent central neck dissection. The primary outcome was symptomatic hypocalcemia within 15 days, assessed using a modified version of the hypoparathyroid patient questionnaire, a validated symptom instrument. So what did they find? Symptomatic hypocalcemia occurred in 11.1% of the PTH-guided group and 7.8% of the routine supplementation group. And this is based on the table 2 of the paper. The odds ratio was 0.68 with 95% confidence interval crossing 1 from 0.29 to 1.57, and the p-value was 0.36. Not significant. One thing to flag here, the abstract of this paper actually reports these numbers in reverse, listing 7.8% for the PTH group and 11.1% for the C plus C group. But when you check the math against the group sizes, the table 2 assignment is the one that works. The abstract appears to have the counts swapped between the groups. In the subgroup with the complete biochemical data, 148 patients, the biochemical hypocalcemia was 21.6% in the PTH group and 17.6% in the routine group. Again, not significant. The main result is clear. Neither strategy was superior to the other. Symptomatic and biochemical hypocalcemia rates did not differ significantly. The more interesting finding is on the practical side. The PTH-guided strategy reduced the need for postoperative supplementation by about 57 to 65%. In the full cohort, only 43% of PTH-guided patients ended up needing supplementation compared to 100% in the routine group. That's a lot of patients spared 15 days of medications. The PTH group did have a numerically higher rate of symptomatic hypocalcemia, 11.1% versus 7.8%. But the difference was not statistically significant. A few limitations to note. This was an unblinded trial, which was unavoidable given the interventions. They used a modified and unvalidated Spanish version of the symptom questionnaire. Only 57% of the patients had a complete biochemical data, and it was powered as a superiority trial, not a non-inferiority trial, which is an important distinction when you are trying to show two strategies are equivalent. So the bottom line, both strategies work. If you have reliable rapid PTH assay availability, the selective approach cuts supplementation use significantly, and the difference in hypocalcemia rates was not statistically significant. If PTH turnaround is slow or costly, particularly in outpatient thyroidectomy pathways, routine prophylaxis works just as well. It depends on your local resources, your workflow, and your preference. This is a solid trial that gives us the first real randomized evidence to support what many of us have been doing by institutional habit. Either way, we are not failing our patients. That's episode 11. Join the club. We'll see you next week. Thank you.